The issue was, though, first of all, how do we know how to apply this, and why was this? So, I think the biggest question is, why would this be? And it's a pretty obvious answer, which most people don't remember. That is, if you think back to your embryology days, you would remember that the right colon comes from the midgut and the left colon comes from the hindgut. So in fact, these are biologically different tissues at the outset. Why wouldn't they behave differently if a cancer arises from them? In fact, they're molecular features that are different on the right versus the left that are not randomly distributed. So this shouldn't surprise us at all. And of course, the side is not the question. It's not like magical right versus left. It's got to do with the biology that tends to segregate on one side or the other. Now, what is the biology? That's a challenge. We think it's got to do with BRAF mutations, which are dominantly on the right side. That does not account for all of the difference. It accounts for some of it. MSI high patients will not do so well with metastatic disease. That's maybe 3%. This does not make up the 14-month difference. We believe it's many factors put together. The other remarkable finding, though, is if we looked at the individual biologics in terms of their activity, bevacizumab was a little better on the left than the right. It turns out cetuximab, the difference was 20 months. Patients with left-sided cancers lived 20 months longer if they received cetuximab compared to the right side. And probably in some, it would be the message that cetuximab does not work on the right side of the colon. And my bet is that when we get the data from, let's say, Crystal study, which is keep FOLFIRI with or without cetuximab, I bet almost all of the benefit, if not all of the benefit, will come from patients with left-sided cancers. Again, why is that? It's complicated, and we don't yet know the answer, but that's where we are.